Thank you for your kind introduction. It is great honor to be here to present my research. I have no financial relationship to disclose. Background: SIJD treatment option. Definitive diagnosis using SIJ injection. After that, I will do pelvic belts, abdominal muscle exercise, movement instruction. About 80% of outpatients improved with these treatments. The three means belts, we use a smart spine SI support, Baracon band, and functional pelvic Tanaka's belt. The treatment of SIJD. The smart spine SI support and the Baracon band are effective when tightened at the back. Functional pelvic Tanaka's belt works on pelvic ring stability, those 3-point fixation of the iliac and pubic bones. Contraction of the transverse abdominis muscle increases SIJ stability. Selective contraction of the transverse abdominis muscle at draw-in. Without ultrasound, check contraction by placing one hand on the navel and the other inside the ASIS. If contraction is felt inside the ASIS, it's indeed excessive activation of the outer muscle. Movement instruction. Spine user. Rapid change in spinal alignment, sharing force at the SIJ. Hip user. Heart forward from the line connecting the two knees. I would like to demonstration. Please come closer. Smart spine SI support. There are two remove parts, and pulley mechanism. Strong pulley mechanism, strong pressure.
And the level is between the trochanter and the iliac crest.
Iliac crest.
Trochanter and iliac crest.
Oh yes, yes. So above that trochanter. Yes. そう。なんか体験してほしいけどね。あ、そうですね。え？そうでした？
Next Baracon band. Baracon band is tightened forward and tightened at the back, and both using Baracon band. ASIS lines. Tighten forward and tighten at the back.
どこを上下にする？威力プレス。
Here.
That's pelvic Tanaka's belt, ASIS and pubic bone 3-point. Many using women 3-point extension SIJ instability.
This band is Japanese original, so it is very effective for female patient with pelvic ring instability. So the patient, postpartum patient, have a pubic symphysis pain as well as sacroiliac joint. This belt is useful to hold the pelvic ring. Okay. Next is ultrasound guided.
Transverse abdominis muscle exercise. Strong contractions are internal muscle, many using next 20% contraction, transverse abdominis muscle.
Where is the transverse abdominis muscle? Oh, yes.
May I ask a question? What are you telling your patient to do to activate just the transversus abdominis? What commands are you giving to the patient on how to move?
そうどういうふうにしてやってもらうかって。
イメージ20% contraction.
20% 収縮してみろって。
Are you telling him to tighten or train it deeply?
20%. So only 20% power will count. Power will count. So
contraction of belly.
yes.
へそをへこますイメージ。
そうへそなんていうんですかね。へそをへこます。英語でなんていうんですか先生。へそをへこます。
お腹に力入れるといいんでしょ。
はい。
To ask the patient to give the pressure on their belly button to go down to the back.
But only a little bit.
Yeah, 20%.
20%.
Yeah, so it's perfect.
So the answer is bring the belly button towards the spine
Yeah.
as opposed to about Valsalva, which is
こっちに来てほしいぐらいです。
It's not a full contraction. Just 20% of your contraction.
Yes.
Strong contractions are outer muscle, many using. 20% exercise internal inner muscle, transverse abdominis using. SIJ joint, transverse abdominis muscle, very important.
So
Inner muscle contraction is effective for the tighten the sacroiliac joint, not outer muscle. Yes.
That's all. That's all.
あラスト
Last movement, stand up. First, spine user, spinal extension, more standing. Many patients are spine user, SIJ high stress. Hip user, hip flexion, no SIJ stress. Drawing, moving before drawing 20% image. After hip flexion, standing, SIJ no stress. Finish. Finish. Thank you so much.
We would like to ask everyone.
Here's a question.
There's a question. Okay.
About that. So I usually give all 3 abdominal exercises for the rectus, then for the obliques, doing the twisting motion. But then I do the belly button pull in, and I emphasize that as one of the best evidence-based. Do you give all 3 of those too? Exercises.
So you done the exercise. You do the exercise for patients. Twist.
Well, so no, I actually they're all flat on their back, and then I have them do like the bicycles, one leg out at a time. That's to get the rectus, and seeing how close. And when they get stronger, then they can use both legs. And then to get the obliques, they just have their knees bent and they go slowly side to side. And then to get the TA, I just have them suck in their belly button and hold it for 10 to 15 seconds and do that a number of times. Do you think that's correct? Or?
So for physical treatment for the sacroiliac joint problem, so you ordered the several type of exercise.
Yes.
Yes. そうだろうね。But the basic. So of course, a physical therapist of mine try to exercise, but basic is transverse abdominal muscle training and pelvic belt in the acute phase. And in clinical case, he often make the program for each patient, so including the bike and stretch with the transverse muscle contraction.
Contract with the belly button.
Oh yes, it's a basic. So this time, there are many sacroiliac joint experts here. So we would like to know how to manage your patient as a physical therapy. So do you have any solution to physical therapy specific for sacroiliac joint? So Thomas, how about your hospital? So physical therapy specific for sacroiliac joint. So you are calling. What kind of things you are calling to do your patient?
We don't really know. We send them to our physical therapist, and then she takes care of it.
I'm sorry, I couldn't catch you. There are no specific physical therapy.
We send our patients that we do not treat surgically, but send to our physical therapists, and then they decide what kind of therapy the patients are receiving.
Okay, I see. So that surgeons don't know how to treat that. Okay.
To that,
We give them some instructions on how to get up and sit and kind of how to try. They're primarily treated by our
Okay,
What if that patient that you're diagnosing has
something that you don't think is SI, or you think it may be, let's just use pelvic floor example again. Will you send them to a different physical therapist?
We were in the hospital that we work, we have one lady who is very interested in these outdated patients.
Okay.
So she sees most of them, and then she has a network throughout her way. She will send her or the patient to whoever she sees most fit in the region that they live in.
So you and I do the same thing. Give our therapists a lot of autonomy to choose what they do for that patient. Right. Yeah.
So how about cartoon? So you made the program for rehabilitation for sacroiliac joint. So your colleague has a very good skill to treat the patients.
I think you have to think about their deficit.
Yeah.
Where is their deficit? What is it that you're trying to correct? And focus on that. And again, you have to partner with physiotherapists that have an interest in this, I don't like an interest in the pelvic floor, an interest in the spine, if it's a post-spine fusion problem with weakness and imbalance. I think there's a huge range of
Yes. So, but recently, a colleague of mine, woman physical therapist, actively learned about the pelvic floor muscle training. So it's very important to treat the female patient with sacroiliac joint dysfunction. So.
There are some of our therapists concentrate on actually trying to manipulate the SI joint and move it and shift it versus core strengthening, TA strengthening. So does anybody have experience with physical therapists that will actually try, like a chiropractor, truly manipulate the SI joint? Or just strengthening? Okay. That's not, it's not.
I agree with what you're saying. Think about muscles. I mean, they really just temporarily move joints and whole things. It's the ligaments and the interlocking of the surface of the joint that really is the long-term 99% of what allows for stability. And my thought is, you get these patients who feel like the joint's out or it slips,
Right.
and we know it doesn't move very much. But you think about it, if those interdegenerations are just off a little bit, the pressure against the rest of the joint is extreme.
Right.
So that when you do that, they feel better when they get back in there in the groove.
Yeah. I feel I have the best analogy on because patients, we all hear patients come in and they say my SI joint is completely out of alignment. We all know that's not true. It doesn't happen. So I think when you walk around in your kitchen without shoes on, bare feet, and you step on a crumb, it feels like a rock. And you look down here and it's just a tiny little crumb. So I think those tiny little movements feel very, very big. And I think that's what they're feeling. Their SI joint's not dislocating, but it's just moving ever so slightly. Okay.
Okay.
Great.
Thank you.
Thank you.
Thank you so much.